Hi, I'm Dr. Emily DeSantis, and I'm a dermatopathologist with Sagis. Today I'm going to be talking about vesiculobullous and pustular dermatitis. This will be the first of a two-part series. And just as an overview, vesiculobullous and pustular lesions encompass a broad category of cutaneous diseases that include both primary and secondary conditions. The primary conditions are predominantly immunobullous disorders, such as bullous pemphigoid and pemphigus, the pemphigus group, and secondary immunobullous and pustular lesions can occur as a consequence of infections, inflammatory conditions, and traumatic processes. The clinical features are really essential for an accurate assessment of the histology. So when submitting biopsies where you're suspicious of a pustular or vesiculobullous process, be sure to always include the age of the patient, the duration, distribution, and size of the lesions. The quality of the blisters is also very helpful to include. So these are characteristics such as whether the blister is flaccid or tense, whether it's on an erythematous base, hemorrhagic, etc. And underlying medical conditions that the patient has should always be provided, as well as medications. So if the patient has had any medication changes or is on any new medications, that can be extremely informative for your dermatopathologist. Histologically, vesicular and pustular lesions can be categorized in a couple of different ways. One is the mechanism of the split. So vesicles can be caused by spongiosis. They can be caused by primary acantholytic processes. So the mechanism of the split is one way that we categorize them. And then we also look at the location of the split within the skin. So this can be with either intracorneal or subcorneal, intragranular, intraepidermal, or subepidermal. So in this talk, we're going to discuss the intraepidermal, vesicular, and pustular dermatitis. These can be divided into two broad categories. The first is intracorneal and subcorneal vesicular and pustular lesions. These predominantly include things such as bullous impetigo, staph scalded skin, subcorneal pustular dermatosis, Pemphigus foliaceus, as well as a few others. And the other broad category is intraepidermal lesions, which includes intraspinous and suprabasilar lesions. Intraepidermal lesions can be caused by spongiosis, as I mentioned previously. This is typically lesions such as contact dermatitis with poison ivy or arthropod bite reactions. And then acantholytic lesions also show an intraspinous or suprabasilar pattern. Some of these are immunobullous lesions such as pemphigus, and then some infectious processes such as herpes and varicella. So we'll start with bullous impetigo. Clinically, bullous impetigo presents as honey-colored crusted lesions and is most often caused by Staph aureus. Histologically, we see a subcorneal or intracorneal collection of neutrophils, so a pustule. And on gram stain, we can see gram-positive cocci. So anytime we see a pustular lesion, we always want to perform stains for organisms, including a PAS stain for fungus and a gram stain for bacteria. The differential diagnosis for bullous impetigo includes staph scalded skin syndrome, which typically does not show the degree of inflammation that bullous impetigo does, and gram stain and staph scalded skin will be negative. Pemphigus foliaceus can also appear histologically very similar to bullous impetigo, but often shows acantholysis and most importantly would demonstrate a positive direct immunofluorescence study. So here we have a slide with a bisected punch biopsy. We have a nice deep punch. And even at low power, we can appreciate that there is definitely something going on in the epidermis. There's some acanthosis. We see some large kind of holes in the epidermis. So these are spongiotic vesicles. And we really want to zoom in on higher power to better evaluate this epidermal process. So again, we see these large spongiotic vesicles. And as we go higher, we can appreciate numerous inflammatory cells within the vesicles. These cells are mainly neutrophils, and we do see a few scattered eosinophils as well, but lots of neutrophils, so a pustular process. The dermis contains a superficial inflammatory infiltrate, kind of a mixed picture with some lymphocytes, some neutrophils, and a few eosinophils. So whenever we see intraepidermal pustules, whether they're associated with spongiosis or not, we always want to perform our stains for organisms. PAS stain on this case was negative, and this is a gram stain. With our organism stains, we always want to look at high power because the organisms can be very subtle and often can't be appreciated at lower magnifications. So when we zoom in on high power, we see a pustule with these aggregates of gram-positive cocci, and that confirms our diagnosis of bullous impetigo. Moving on to subcorneal pustular dermatosis, also known as Sneddon-Wilkinson disease. Clinically, this classically presents in the intertriginous areas of middle-aged women and can appear as flaccid pustules on an erythematous or normal flesh-colored base. Histologically, it's a very characteristic picture of a well-defined subcorneal pustule. It's often a broad pustule. There may be some acantholysis at the edges of the blister, but often there's no acantholysis. And the differential diagnosis includes IgA pemphigus, which would demonstrate a positive direct immunofluorescence, pustular psoriasis, which typically shows a background of psoriasiform change or psoriasiform lesions otherwise on the patient. Acute generalized exanthematous pustulosis, which we will discuss next. And again, we always have to think about an infectious process when we see subcorneal pustules, so dermatophyte or impetigo. So this is a punch biopsy. And at low power, we can appreciate there doesn't appear to be much happening in the dermis, but in the epidermis, we have this very well-defined subcorneal lesion. The epidermis on either side of this appears fairly unremarkable. So we zoom in and we can see that within this subcorneal split, we have a collection of neutrophils. So this is a nice example of a very broad subcorneal pustule that we would see in subcorneal pustular dermatosis. And again, we always need the clinical picture to definitively make this diagnosis, since there are other things to consider in the histologic differential. So it's really a combination of the clinical and the histologic findings. Acute generalized exanthematous pustulosis, another pustular entity that certainly requires clinicopathologic correlation. Clinically, most of these cases are associated with medications. So most commonly, they're associated with antibiotics or antifungals. Calcium channel blockers have also been implicated. And this presents as a rapid onset of erythema and non-follicular pustules. Patients can have fever and other systemic symptoms. And histologically, there's kind of a mixed histologic picture of spongiosis, some intraepidermal or subcorneal pustules. There can be areas of dyskeratosis or acantholysis, but not necessarily And then there's a dermal inflammatory infiltrate with eosinophils and neutrophils. So the differential here also includes pustular psoriasis, which would not typically show spongiosis or eosinophils. Subcorneal pustular dermatosis, which we discussed, shows that broad, kind of clean subcorneal pustule, and does not show spongiosis. But we really do need that clinical history of new medication, most often recent antibiotic use, and the systemic symptoms. So in this case, we have a bisected punch biopsy, and at low power, we see some epidermal acanthosis and large spongiotic vesicles within the epidermis. There are inflammatory cells within these vesicles. And as we zoom higher, we see numerous neutrophils, as well as some scattered eosinophils within the dermis, and a few eosinophils within the spongiotic vesicles as well. So this combination of pustular and spongiotic dermatitis with neutrophils and eosinophils is certainly suggestive of AGEP, and we would want to consult with the clinician to find out whether the patient has been on recent medications, what else is happening clinically, and then we would always want to perform our stains for organisms to rule out those things. This case, on the other hand, is another bisected punch biopsy. And at low power, it doesn't appear as spongiotic as the previous case of AGEP, but there is a bit of mild epidermal acanthosis and possibly some areas of spongiosis as well. And as we go higher, we see a nice subcorneal to intraepidermal aggregate of neutrophils. So another pustular process with a superficial dermal inflammatory infiltrate containing lymphocytes, a few neutrophils, and occasional eosinophils. So again, this could be a case of AGEP. It's not quite as spongiotic as the previous case, but with spongiosis and pustules, we certainly would want to consider that. But again, we would want to perform our stains for organisms. And when we do, this is our PAS stain, we would see, as we zoom in on very high power to evaluate this stain, we start to appreciate some yeast forms and small hyphal elements within the stratum corneum. Here are some more hyphae. So this is a case of dermatophytosis. So you can see how there can be a lot of histologic overlap among these entities, and the clinical history and clinical pathologic correlation is extremely important in helping to arrive at the correct diagnosis. So moving on to intraepidermal vesicles that are the result of spongiosis or edema. This is most commonly seen with allergic contact dermatitis. Could be contact dermatitis to any allergen, but poison ivy is very classic. And arthropod bites can also have this histologic presentation. Arthropod bites often appear on the lower extremities, and scabies infestations can also present with a diffuse vesicular bullous eruption. Histologically, we see intraepidermal spongiosis, so acute spongiosis with vesicle formation, can be microvesicles or macrovesicles, with occasional foci of epidermal necrosis. And a big clue in these cases is the dermal infiltrate, which can be superficial or superficial and deep. in a perivascular and usually also interstitial pattern with eosinophils. So whenever I see a biopsy with spongiosis, a superficial and deep pattern, and numerous eosinophils, the number one possibility on my differential diagnosis is an arthropod bite reaction until proven otherwise. So here's another slide of a bisected punch. And in this case, we see some epidermal acanthosis. We don't necessarily appreciate a lot of epidermal spongiosis in this slide, but what we do see is prominent subepidermal edema. So when we see subepidermal edema, that can clinically present as a vesicular eruption. When we zoom in on higher power, we see a superficial and deep inflammatory infiltrate, predominantly in a perivascular pattern, but also with quite a few interstitial cells. And this infiltrate, as you can see, contains abundant eosinophils. So whenever I see this pattern, I go to kind of the deepest aspect of the biopsy to see if I'm still appreciating eosinophils. And if I do, then I'm really strongly considering an arthropod bite reaction. Also, when I see this picture, I typically scan the epidermis again to see if I do find any indication of scabies. And if not, I will often perform additional tissue levels just to see if any scabies mites or mite parts appear. If not, it does not exclude the possibility of scabies, but it is certainly very helpful when we do find it. So now we'll move on to intraepidermal vesicular bullous disorders with acantholysis. This predominantly includes the Pemphigus group, Pemphigus vulgaris, Pemphigus foliaceus, as well as other forms of Pemphigus. Some infectious processes, particularly herpes, can show acantholysis. And then in the differential diagnosis of these disorders, we have Derier's disease, Haley-Haley disease, and Grover's disease. These are discussed in more depth in the happy hour session entitled All Things Acantholytic. So I would encourage you to refer to that talk to go into more detail about these entities. Pemphigus vulgaris clinically often presents in the 4th to 6th decades and is very uncommon in children. It presents as flaccid bullae on normal to somewhat erythematous skin, often in the head and neck and upper trunk areas, and it can also involve the mucosal surfaces, so oral mucosa and conjunctiva. Histologically, there's a very characteristic picture of a suprabasilar acantholytic vesicle. The acantholysis can involve adnexal epithelium. So acantholysis involving follicular epithelium is very characteristic of Pemphigus and helps to exclude other entities in the differential diagnosis. All of the Pemphigus entities often include eosinophils within the inflammatory infiltrate, and direct immunofluorescence is really essential for a definitive diagnosis. So in Pemphigus vulgaris, direct immunofluorescence will show a characteristic pattern of intercellular IgG and C3. And then, as I mentioned, Haley-Haley, Grover's, and Derier's are included within the differential diagnosis. And this photo shows a picture that we often get in biopsies of Pemphigus where there's a suprabasilar split and the remainder of the epidermis is not even present in the biopsy. So we're really just working with the basal layer, but the presence of an intact basal layer is very characteristic and suggestive of Pemphigus. So this is a punch biopsy. Pemphigus can be fairly subtle histologically or show more exuberant features. There really is quite a range. And at this power, in the center of this lesion, we may consider a spongiotic process. But when we fully evaluate the epidermis, we can see that there are areas of suprabasilar vesicle formation. And over at the edge, we see this very classic tombstoning appearance where the basal epithelial cells are still kind of hanging on and they're intact, but you can see the individual cells and they appear as tombstones. And then the dermal inflammatory infiltrate is fairly mild, consists of predominantly lymphocytes. And I don't necessarily see a lot of eosinophils in this case. So in this case, we would be very suspicious of pemphigus and would suggest direct immunofluorescence studies. This is another biopsy of pemphigus. This is a shaved biopsy. And again, we see this nice suprabasilar cleft with intact basal cells demonstrating a tombstone appearance and a few acantholytic cells floating within the vesicle. Pemphigus foliaceus most often presents in young to middle-aged adults. It often involves the head and neck and upper trunk and presents as superficial vesicles or possibly just erosions showing a rim of blister. So there may be no intact vesicles. Histologically, Pemphigus foliaceus shows a subcorneal vesicle with occasional superficial acantholysis, not always. And again, we see eosinophils. We can see eosinophilic spongiosis, and neutrophils may or may not be present. The direct immunofluorescence is similar to that seen in Pemphigus vulgaris, although the IgG and C3 may be most prominent in the upper epidermal layers. The differential diagnosis includes staph scalded skin, bullous impetigo, as well as other forms of pemphigus. And in this photo to the right, this is an example of Pemphigus foliaceus where we may not necessarily see the stratum corneum. So in this case, what's missing from this epidermis is actually the clue. We do not have a stratum corneum. We have only a really small amount of granular layer. So it's important to be able to recognize not only what we do see in a biopsy, but what may not be present. And here is an example of punch biopsy. And as we zoom in, we see intact stratum corneum with this subcorneal split. We see a few acantholytic cells that are these discohesive cells within the vesicle, and some inflammatory cells, which include neutrophils and some eosinophils. So this actually appears quite similar to the case of subcorneal pustular dermatosis, except this case does show the acantholysis. So we could consider subcorneal pustular dermatosis in this case as well. And we would certainly want to perform our PAS and Gram stains. And depending on the clinical presentation, we would suggest direct immunofluorescence studies to confirm our diagnosis. Drug-induced pemphigus can present clinically very similar to Pemphigus vulgaris or Pemphigus foliaceus. About 80% of these cases are associated with penicillamine. Captopril is also indicated, as well as some additional drugs, including penicillins, cephalosporins, NSAIDs, and enalapril. The H&E findings and the direct immunofluorescence findings are similar to Pemphigus vulgaris or Pemphigus foliaceus. So the key in these cases is to recognize that a new drug has been initiated and to make that correlation. Most cases will resolve with discontinuation of the drug. Pemphigus vegetans is very uncommon. It predominantly is seen in intertriginous areas and presents as these very hyperkeratotic, verrucous pustular lesions. So histologically, we need to have a very high degree of suspicion for these cases because they have a lot of overlap histologically with deep fungal infections or mycobacterial infections. They show verrucous hyperplasia with pseudoepitheliomatous change, and there are prominent intraepidermal pustules that they may or may not show eosinophils. There may be areas of acantholysis, but not always. And then the direct immunofluorescence studies will be similar to Pemphigus vulgaris, which will be diagnostic. And this is a case of Pemphigus vegetans. It's an older slide, so it's a bit faded, but these cases are rare, so we have to hold on to the ones that we do find. But you can see at low power this kind of papillomatous, verrucous appearance of the epidermis. And at higher power, there appears to be some acantholysis. We don't even really see a granular layer or stratum corneum, so this is actually the entire epidermis is a vesicle or a split, and the acantholysis extends down into the follicular epithelium as well, which is always a clue that we're dealing with pemphigus. And we have a fairly brisk dermal inflammatory infiltrate with lymphocytes and a few eosinophils. So direct immunofluorescence would be diagnostic in this case. And in some of these cases, if we do see just this very verrucous appearance and kind of a pseudoepitheliomatous picture, we would want to perform stains for not only PAS, but also AFB, phyte, to rule out a deep fungal or mycobacterial infection. Paraneoplastic pemphigus also requires a very strong degree of clinical suspicion. It's extremely uncommon and difficult to diagnose clinically and histologically, and we need very specialized studies to make the diagnosis. Clinically, this can present with findings similar to pemphigus, to erythema multiforme, or even lichenoid dermatitis. And histologically, there are a range of presentations as well. So we may see interface change. We can see, as in this case, this photo on the right, we see eosinophilic spongiosis, so intraepidermal eosinophils without any acantholysis, and maybe a suggestion of interface change. Direct immunofluorescence will show IgG and C3 in an intercellular pattern and also along the basement membrane zone. So it's a mixed picture. And then to really definitively make the diagnosis, we perform indirect immunofluorescence on rat bladder epithelium, which would be definitive. So as you can see, we really need to really have high clinical suspicion and put all of these findings together to arrive at the diagnosis. This slide lists some of the autoantibodies seen in the pemphigus variants. This is important for testing purposes, since these are things that do tend to appear on exams. Pemphigus vulgaris is most commonly associated with antibodies to desmoglein 3 and desmoglein 1. Pemphigus foliaceus is desmoglein 1, 165 kilodaltons. Paraneoplastic pemphigus encompasses a number of different autoantibodies, and a few of them are listed here. And then the last entity that we will discuss for intraepidermal acantholytic processes is herpes virus. This can be herpes simplex virus or varicella zoster virus. It clinically presents as grouped vesicles on an erythematous base. And as we saw in our previous talk on interface dermatitis, histologically, herpes can present with an erythema multiforme-like pattern with dyskeratotic cells scattered throughout the epidermis. We may see areas of epidermal necrosis, And we can also see an intraepidermal or subepidermal vesicle with acantholysis. Sometimes these lesions are just entirely necrotic, but if we see an intraepidermal vesicle with acantholysis with diffuse necrosis, that's always very suggestive of herpes virus. Viral cytopathic effect, which we can see in this slide, is characterized by the 3 M's. So those M's are multinucleation, molding, where the nuclei mold to each other, and margination, which refers to margination of the chromatin to the outer edges of the nucleus. This is a slide showing an intraepidermal vesicle and a dermal inflammatory infiltrate in a perivascular and perifollicular pattern. And as we zoom in on this vesicle, we see these scattered individual acantholytic cells, and then these nice intranuclear inclusions. So we see a nice example of molding, margination, where the chromatin appears darker around the periphery of the nuclei, and molding. So this is an example of herpes, and we could perform immunohistochemical stains for HSV1 and 2 and varicella zoster if it isn't clear clinically which one of those is the pathogen, or we could just sign this out as herpes virus infection. So that concludes this talk, and our next session, we will look at subepidermal vesiculobullous dermatoses, and I will see you then. Thanks.